All right, so good afternoon, everyone. Thank you for joining us. My name is Eliana Landa, and I'm the Physician Relations Specialist here at Rothman. Today's webinar is with Dr. O, our sports surgeon. His office locations are in downtown, the Training Center, Innovation Tower, and Winter Park. Topic that he will be covering this afternoon is how to treat and manage shoulder dislocations. So just a few quick notes. At the bottom of your screen, you will see a Q&A icon where you can enter any questions that you may have throughout the presentation. Dr. O will have time at the end to answer as many questions as he can. And then also in the chat box, I will share Rothman's phone number if you would like to make an appointment, as well as my information for any assistance that you may need. This webinar is being recorded and you will be emailed and the recording within a few days. So without further delay, I will pass this off to Dr. O. Welcome, Dr. O, and thank you so much for your time this afternoon.
Thank you, Alana, for your introduction, and it's a pleasure to be here. Wanted to take this time to have what I would consider to be an informal conversation, kind of a fireside chat about shoulder dislocations and subluxations. And so we'll stop in some key moments in the presentation to ask for any questions or clarifications, as well as at the end. So when we're talking about dislocations and subluxations, I wanted to start off by mentioning something that one of my mentors had taught me, which is how to talk good. And this was one of these examples. What would you feel if you heard someone say, the patient disloced his shoulder twice last month? Something doesn't sound right. And well, let's look at the words now. We have the words dislocation and subluxation. The verbs of those words would be dislocated and subluxated. So sublux is the less preferred term than subluxated. So I tell our residents that I will allow them to say and use the word subluxed if they also use the word disloced. So if you're not going to use disloced and use dislocated, then I would suggest that you also use the word subluxated. So let's move on now. So when we talk about shoulder instability, what do we really mean? What's the shoulder? And so in the shoulder girdle, this particular artist would propose that there are 5 joints in the shoulder. And this person included the subacromial space as a joint in the shoulder. I think many of us would probably not consider that to be a joint in the shoulder, a formal joint anyway. It is a joint in that there are 2 bones that meet, but that's in the impinging position. And so unless you have a massive rotator cuff tear that results in a high riding humeral head and causes acetabularization of the acromion, most people would not consider the subacromial space as a true joint. And when we have acetabularization, we refer to that as a pseudo joint, I suppose. So I think for most people, classically, there are 4 joints in the shoulder girdle. You have the sternoclavicular joint, which is what connects the shoulder girdle to the axial skeleton, the acromioclavicular joint, the glenohumeral joint, and the scapulothoracic joint. And so there are some other purists who will say that if you will define a joint as one that has cartilage as the interface, then there would be 3 joints in the shoulder, because the scapulothoracic joint does not have a cartilage on cartilage articulation, but has some synovial lining and bursal tissue there. So for the purposes of this talk, we will be focused on instability of the glenohumeral joint. And so let's look here. Hang on, let me just see if there's some comments in the chat. So I just want to make sure. Okay, great. I want to make sure that everyone can hear me in case there was a comment about that. So we have the shoulder and the hip. They're both ball and socket joints. But why do we have so many more shoulder dislocations compared to hip dislocations? And so let's look at the way that the joints are constructed. So just by looking at the x-rays, what I wanted to impart on you is that the socket on the hip seems to cover almost about 40% or so of the circumference of the femoral head. Whereas on the shoulder, you can see that perhaps it covers maybe 25% of the ball part of the humeral head. So the coverage by the socket is much more shallow in the shoulder. And of course, the advantage of that in the shoulder is that we have greater range of motion compared to the hip. But the price we pay for that is instability. It's easier to dislocate. So let's look at the hip joint. Both the hip and the labrum, both the hip and the shoulder have a labrum, which is a circumferential O-ring that goes around the socket part to deepen the socket and also helps with some compression and suction effect, if you will. In the shoulder, we have a labrum as well, but you can see how the labrum looks more like a dish rather than a bowl that you would think of in the hip. And so it's a much shallower situation. And as both pictures showed, you can have tears in the labrum there. So many times when we talk about shoulder instability, we liken it to a golf ball and a golf tee. And so if you were to have even a tiny piece of the wooden tee chipped off, then the golf ball would very easily fall off in that direction. And so similarly in the shoulder, we need to be keeping an eye out not only for labral tears, but also any very subtle tears or injuries to the bone on the socket itself. Okay, so there's a Matson classification of two different characteristics and personalities of shoulder instability. The one we're going to be focused on for the purposes of this talk is the type that's described on the left, which is the TUBS, that there's a traumatic injury mechanism, that the dislocation occurred in one direction. And Bankart, we'll talk about in an upcoming slide. The Bankart lesion is a classic labral tear that was described by Dr. Arthur Bankart. And usually the typical treatment recommendation is to undergo surgery. Now, on the right-hand side, we see the Ambry type, which is a shoulder instability without any injury mechanism. It's atraumatic, and it's multi-directional, that it goes in and out in multiple directions. Often it happens to both shoulders, and the typical treatment is not surgery, but to undergo physical therapy and rehabilitation. And that there's also an inferiorly directed instability as well. And we'll talk about some of the physical examination tests that can help us assess some of those types of conditions. And of course, you can have some overlapping circles in the Venn diagram where you can have someone who has at baseline physiologic laxity. They're very stretchy and they have loose collagen to begin with. And those patients, of course, can have traumatic injuries that then tear the labrum further. And in those cases, there would be a case for performing surgery so that we can get those patients back to their usual baseline level of shoulder laxity, if you will. So another way to characterize the difference is that on the left side, you had an injury that caused your instability. So we refer to that group as the ones who are torn loose, whereas those on the right who through either hereditary factors or other collagen disorders, perhaps, that they were born loose. So we're going to be talking about the TUBS, traumatic injury, injuries that cause shoulder dislocations. So let's start off here.
Was having what many would argue the best season in PBR history, but it may have come to a crashing halt last night here in Chihuahua, Mexico. Amidst all the fanfare, McBride was last out the chutes in round number one, and it all started typically enough, as most rides do for Justin, but his season may have changed dramatically at around 4 seconds, doing his best to get out of the way of Nash. McBride took a couple vicious hits. He would hit the turf, and then, well, a picture is worth 1,000.
Well, so that clearly is a case of a traumatic injury mechanism. And I know we have both clinicians and non-clinicians in the audience on this meeting, but wanted to review how you would treat this patient and what are the different things that you should be thinking about as you meet this person, whether it's a sideline of a football game or at a rodeo. versus meeting them as a provider in the emergency room versus as a specialist who was seeing this patient for consultation after they had been initially treated in the emergency room and now seeing you in your office. So let's say in the emergency room, you get x-rays and you see this. Clearly, the humeral head, the ball is off from the socket and it's dislocated, but you see this other fragment here that looks like it's a broken piece. And some may attempt to perform a closed reduction where you're performing different maneuvers to basically pop the shoulder back in. And after the first attempt, let's say you get an x-ray and it shows this. This is, of course, when you shriek and you say, oh my God, now the situation's gotten worse. It looks like the humeral head is now split and there's a proximal humerus fracture. And so if you go back to the prior x-ray and study it carefully, not only do you see that extra broken piece here, but there's also a lucency going across the neck of the humerus. And so that's a non-displaced fracture that exists. And so if you perform a closed reduction, the shaft of the humerus will be able to be pulled as you're manipulating the upper extremity to reduce it. But because of that fracture, that humeral head stays in place. And so you can displace that and cause a worse situation here. At times in situations like this, if you're calling an orthopedic specialist, then we may come down and use a fluoroscopy in order to try to visualize what we're doing as we're performing a reduction. And if we cannot achieve it, then we have to go to the operating room to do an open reduction. But in this case, let's say a closed reduction was successful using fluoroscopy, and now the shoulder is back in place, but you can see that it doesn't quite look normal in terms of contour because there are some fractures there. So typically, patients we're seeing in the emergency room will say, go see an orthopedic surgeon within a week. And many times it's difficult to see the specialist within a week, but let's, for argument's sake, that it is a week or perhaps two. And in the orthopedic surgeon's office, we take x-rays and now the shoulder looks like this. So the question is, what happened during the ensuing week or 2 weeks that resulted in this problem? So obviously there's an inferior subluxation or dislocation. Dislocation meaning 100% displacement, where subluxation means partial. So it could be argued you could classify this as a subluxation or a dislocation, I suppose. One of the dramatic things to notice is that if you look at the contour of the deltoid, it looks rather flat, doesn't it? But let's just look at the previous x-ray. On this x-ray, the deltoid contour is rather full. And so what had happened during this time is that there has been atrophy of the deltoid with deltoid atony, and therefore, just with the weight of gravity, the humeral head is being pulled down because you don't have the deltoid muscle firing to keep this in position. So you know that the deltoid muscle is innervated by the axillary nerve. And from this diagram, you'll see that the axillary nerve drapes right underneath the humeral head. And so if you should have a subluxation or a dislocation, which is typically in the anterior and inferior direction, you will be pulling on the axillary nerve and causing a traction injury, just like pulling on a bungee cord, if you will. And so with a severe dislocation injury mechanism, you can injure the axillary nerve. And so that's why for every shoulder dislocation patient, whether you see them on the sideline, in the emergency room, or in your office as a musculoskeletal healthcare provider, you must document a neurovascular exam that includes the axillary nerve distribution. So the often used abbreviation of NVID intact, neurovascularly intact distally, is not good enough because you need to document the axillary nerve exam, which includes testing for sensation at the insertion site of the deltoid, and also testing for muscle firing of the 3 different components of the deltoid, the anterior, the lateral, and the posterior head. So even after a dislocation, you can test that pretty easily by positioning their arm into about, say, 20 degrees of abduction. and just ask them to hold it in that position. And even if they've dislocated just hours ago, they would be able to hold that position before you discharge them from the emergency room. So by asking to hold that position, you're going to push their elbow back toward their waist, and they're resisting you. And by putting your hand on the lateral, anterior, or the posterior, and directing them to move their shoulder in particular directions, you can test for the firing of those fibers. And as long as they're firing those muscles, then you know that the motor function of the axillary nerve is intact, and you need to document that. So here are some of the other things that are important. I mentioned to you that if you have a golf ball and a golf tee and you have a very small 1 millimeter chip off the wood on the tee, then it's much easier for the shoulder to dislocate, for the ball to fall over, and it's no different in the shoulder. So you need to look for subtle injury of the glenoid bone. If there's a little chip that happened, then that becomes significant in the decision making for treatment of different athletes that may be going into different sports. The other thing to note is that classically, when the shoulder dislocates, the ball will go out the front, and as it comes back, it will have an impaction against the anterior glenoid rim. That can certainly cause a labral tear, but it can also create a fracture of the glenoid bone. But since that glenoid bone often is harder than the posterior superior cartilage and bone on the humeral head, that's how you get a Hill-Sachs lesion created. Other things to note, if you have a young high school collegiate athlete with a shoulder dislocation, the weakest link is the labrum. So classically, they would injure their labrum. If you have someone who's older, perhaps in their 70s or 80s, with osteoporosis, who have a similar injury mechanism, they may get a proximal humerus fracture because the weak link in their shoulder girdle are the osteoporotic bones. In midlife, and that could be in the 40s, 50s, as well as 60s, I suppose, if you have a violent traumatic injury mechanism that causes a shoulder dislocation, there's another tissue that has now become weakened throughout the course of life, and that's the rotator cuff. So if you have someone in midlife who had a dislocation and they have difficulty raising their arm, that raises a suspicion for a rotator cuff tear. So for a young individual with a dislocation, once you reduce their shoulder, they're able to lift up their shoulder. It may hurt because it just had recently been reduced, but in others, despite the shoulder being put back in place, if they can't raise their arm, then typically an MRI is performed to rule out a rotator cuff tear. So let's say you're covering a football game or a volleyball game. You're at a rodeo. You're the sideline covering clinician. You're the ATC. You're the physical therapist. You're the physician on the field. And you're watching injuries of this type, and you're concerned about things like shoulder dislocations, ACL tears, and the like. What goes through your head when you see an athlete go down? And although we're talking about shoulder dislocations in this particular talk, and I've given other talks about ACL tears and the like, again, as musculoskeletal specialists, we tend to focus on that. But again, when you're the physician on the sideline, you are a physician and you need to be assessing the entire athlete from head to toe. So we can't forget about concussions and evaluating for that. You can't forget about cervical spine injuries, which could be devastating if not addressed appropriately and managed well initially, as well as abdominal injuries. There have been people with spleen lacerations, liver lacs, and other GI injuries in the abdomen that could become very urgent in emergent situations, and those cannot be missed. So we still need to do the full assessment rather than just focusing on a particular joint that seemed to have been injured at the time of the injury event. So let's switch gears here now, just to look at the anatomy. We've been talking about the labrum that surrounds the socket of both the hip joint and the shoulder joint. If you remove the ball part on the shoulder and just look at the socket en face, It's actually not a circular structure. It's not round. It's pear-shaped, the shoulder glenoid, and you have the circumferential labrum here on the left side. The classic anterior labral tear is called a Bankart tear, and it accounts for the vast majority of anterior dislocations. Dislocations in the anterior direction is the most common. In some cases, you can have posterior labral tears where the shoulder subluxates or dislocates posteriorly. Most classically, it's a subluxation posteriorly rather than a dislocation where it's completely out the back. These types of injuries you see more in folks who are, say, a lineman in football, where they have their arms up in front of them and they're blocking, and so their humeral head gets jammed toward the back of the shoulder, and it can create a posterior labral tear. Superior labral tears, the slap tear, are more commonly seen in overhead throwing athletes, baseball players, javelin throwers, and overhead sports. You can have tumblers as well, gymnasts and cheerleaders also can certainly get these types of injuries with all of their overhead work that they do. And you can also have a panlabral tear. Occasionally we see some big tears with collision sports, football, hockey, etc. I've actually seen it in a baseball pitcher once. I used to give this talk about biomechanics in the shoulder, where the forces generated in the shoulder in a 95 mile per hour pitch is enough to dislocate your shoulder right out of the socket. But of course, we don't dislocate our shoulder with a single pitch because of all of the surrounding muscles that help control the shoulder and offer eccentric control. And then I actually met this collegiate pitcher who was pitching in the Cape Cod League, and he threw a single pitch, dislocated his shoulder. They reduced it on the field, and he came to see me the next day, and he had a 360-degree labral tear. And so that is possible, and it's consistent with what we understand about the biomechanics of the shoulder. So here is a classic anterior Bankart labral lesion. You have the golf ball on the golf tee on the left side. The glenoid is surrounded 360 degrees by a labrum, and if the right side is anterior and there's been an anterior shoulder dislocation, then you can have a tear of the labrum. This is a classic situation, but there are a lot of different varieties of how shoulder dislocation event can lead to different types of injury patterns. The Bankart lesion is named after Dr. Ardley Sidney Blundell Bankart, who first described this, as well as the procedure to try to stabilize it surgically. So there are a lot of different classifications and varieties of injuries that we refer to as alphabet soup. On the upper left, there is a normal anatomy. The relationship between the glenoid and the labrum, and the classic Bankart lesion is that just that the labrum has been torn. If you have a piece of articular cartilage that's also torn in addition to the labral tissue, that's referred to as a GLAD lesion. Glenal, humeral, labral, articular cartilage delamination type of a lesion. You have a Perthes lesion that goes around the back and has some stripping of the periosteum. You can have an ALPSA lesion where you have something that started as a Perthes lesion, and the entire labral tissue and complex has migrated medially and scarred down at the neck of the glenoid. And then you can have a bony Bankart. We have a little fracture of the tee, so to speak, on the golf ball and the tee analogy. Now, we talked about the injury to the labrum, but if a shoulder dislocates, it is theoretically possible to have the injury occur not at the labrum, but on the opposite side, right? Meaning on the humeral side, and tear the inferior glenohumeral ligament from the opposite side from the glenoid. If that happens, it's called a Hagel lesion, a humeral avulsion of glenohumeral ligaments. And if you take a piece of bone out, that's called a bagel, bony humeral avulsion of glenohumeral ligaments. You can have a gagel, which means that the labrum is intact, but the inferior glenohumeral ligament in isolation has been torn from the glenoid side, glenoid avulsion of glenohumeral ligaments. You can have a Ragel or a Fagel, which means it's a reverse Hagel. And you can have a floating Agel. These are very rare situations where you can have a tear of the inferior glenohumeral ligament on both sides, both the humeral side and the glenoid side. That usually is associated with an extremely high mechanism of injury. Axillary pouch tears can also happen as well, where the attachment on the bone is intact, but the inferior glenohumeral ligament is torn. So in all of these cases, because there's a disruption of what we refer to as the inferior hammock of the shoulder, there's going to be instability. Again, most commonly it's on the labral side, on the glenoid, but you can have an injury throughout the course of the inferior glenohumeral ligaments. All right, so some of the highlights I wanted to make mention on physical examination is obviously range of motion. You would start with to assess what the patient's capable of performing or not. I think Baton's test for physiological laxity is important. And so you can see on the pictures to the right side that there's some individuals who are very flexible, and starting from the upper right-hand side there, that their pinky MCP, they can pull it back and it hyperextends beyond 90 degrees. There are individuals where they have their arms straight out in front of them, palms facing up classically, and they're able to bend their elbow backwards into hyperextension. On the lower right is the ability to take your thumb and bend the wrist and have the thumb touch the forearm. And then on the lower left, I certainly can't do this, but if you can stand up with the knee straight and palm the floor by bending forward, that also suggests quite a bit of physiological laxity. And then the upper left is that, again, the knee bends backwards, so there's hyperextension of the knees. So you get a different number of points for these, and the highest Baton score is a 9. And so if someone has physiological laxity, then they are more likely to have the Ambry type shoulder instability, where there's no injury per se, but their shoulder and other joints have a level of physiological laxity where there's just a high risk of having an injury. So patients with a high Baton score have a higher risk of shoulder dislocations, patellar dislocations, as well as ankle sprains. The next is a lot of people mispronounce this, but this is a French surgeon, Gage hyperabduction test. So when you perform this maneuver, you have the scapula stabilized, and then you're performing an abduction maneuver on the shoulder. For people who don't have physiological laxity, their abduction test takes them to about 90 degrees, perhaps 100 degrees or so. But if an individual is able to hyperabduct greater than 105 degrees, that suggests laxity of the inferior glenohumeral ligament. And so by definition, this has a correlation with multidirectional instability. So an important test to use in your clinics. Sulcal sign is another test to assess for potential inferior subluxation that's possible of the humeral head. There are different grading systems here when you're pulling the arm down, either at neutral rotation and different degrees of external rotation. The apprehension and relocation tests, I think, are pretty classic. I just wanted to make a note about how to perform it in your clinics. I know in all of the textbooks, the drawings will have the shoulder at 90 degrees of abduction and 90 degrees of external rotation. As a recurrent shoulder instability patient myself, I can tell you that if you put my arm in this position, it doesn't really elicit apprehension. The key maneuver to add, in addition to the 90 degrees of abduction and 90 degrees of external rotation, is horizontal abduction, meaning the arm has to be back behind the patient with the hand positioned such that it's in the cocking position for throwing. By adding that, that makes the shoulder very at risk for subluxation, and that's what creates the apprehension. And so I would encourage you to make sure that you add that horizontal abduction component in addition to what typically is shown in the diagrams. Imaging studies, we classically rely on an MRI, some version of it, as well as CT scan. In some cases, if you have a bony Bankart lesion and a fracture of the glenoid, then you can see those on X-ray. But nowadays, I think the vast majority of us will rely on an MRI. And so there's some controversy between getting a regular MRI without contrast or obtaining an MR arthrogram where contrast dye is injected into the glenohumeral joint. My preference, if I'm looking for a rotator cuff disease or injury, is to get a regular MRI. But when I'm looking for instability and looking for subtle labral tears, my preference is for an MR arthrogram with IV contrast dye placed into the joint. And that's because with intra-articular contrast, the fluid will seep underneath any different layers of tissue that's separated and show me that separation. Whereas without contrast, you may not be able to see it because it just simply sits over the other tissues and you may not appreciate the subtle tears. Some people prefer CT scans, particularly if there are concerns about any bony fracture of the socket, or if there had been recurrent dislocations and that there may not be a frank fracture piece visible, but that the glenoid face has been eroded over time, as you see here, that this doesn't look like a pear shape because it's missing the front part of the bottom of the pear. So some people will get a CT scan and then add intra-articular contrast dye. And the reason for this is that the CT scan allows them to see the bony deformities better or bone loss, and the contrast dye allows them to see the contour of the labrum, as you can see here. Again, my preference is MR arthrogram. I prefer to avoid radiation through CT if I can help it, and MRI, as you know, does not have radiation. At times, if I need to look for a subtle bony lesion, then I may get a CT scan after we've had the MR arthrogram performed. The other advantage of an MR arthrogram is that we can add what's called an ABER view. That stands for abduction external rotation view. And the patient goes into the MRI scanner in the position that you see on the lower left-hand side, where the shoulder is abducted and external rotation. So basically, this is that cocking position of throwing, as I mentioned to you, that creates the greatest stretch of the damaged tissues that are classically injured in a shoulder dislocation or subluxation event. And so on the right side, you can see how the arm is now pointed up, and where the arrow's pointing, you can see very clearly the separation of the labrum from the glenoid bone. So it really helps me to see and make it more obvious what the pathology is and what we need to accomplish if we need to perform surgery. One of the current research that's ongoing at Rothman, Florida, is that so many people come to see me after having had an MRI already done somewhere else that was ordered by another provider, and using MRI to assess for bone loss, because historically CT scan showed the bones the best and MRI showed the soft tissues the best. But in order to decrease the need for the patient to go and get a CT scan that adds radiation, we're working on research to take the MRI images and to convert them through the computer and to program it in order to give us a CT-like picture. And so the left side here shows what a 3D CT scan looks like, and on the right side, it's a rendering using MRI cuts. And so it's, it looks pretty good, very comparable. And so this may become the future where we may not need to subject patients to higher doses of radiation through a CT scan. So in terms of treatment, there's surgical treatment and there's non-surgical treatment. There's been a study from Japan, Dr. Itoi, who places patients in an external rotation sling to see if that would increase the healing of the labrum by positioning the labrum into perhaps closer apposition across a torn interface. And although there seemed to have been a decrease in recurrence rate, that study had been criticized because of the patient that were included in that study. So classically, younger patients have a much higher redislocation rate. And as we get older, the redislocation rate goes down naturally through both the selection of different types of activities for teenagers that are different than 40-year-olds that are different than 60-year-olds. And so the patient studied for this particular research was all over the place. They included people in their 50s, where by definition, their recurrence rate would be lower. So if the study had been performed using patients, say, from 15 to 30, I think that would have been more powerful. But since included patients in age groups where they're not expected to redislocate again, it's unclear if the external rotation sling was actually the reason why they didn't redislocate, or if just based on natural history, they were at low risk to redislocate again anyway. We can have a whole separate lecture on the role of physical therapy and what exactly to do. But just as a general principle, what's important here is that physical therapy after a dislocation event is useful to help with range of motion and to restore their movement, and also to work on scapular stabilization and strengthening the muscles around the shoulder girdle so that they can have their overall function improved. The problem with relying only on physical therapy to get patients back to playing contact or collision sports is that when you're playing sports, it requires unanticipated movements, right? So you have a defender in front of you, and you're trying to do something with your arms, whether you're playing basketball or you're playing football or whatever the sport may be. And if you can anticipate the direction of the impact on your shoulder, as well as the magnitude of that force, if you can anticipate that and predict that, you can fire the appropriate muscle groups in your shoulder to stabilize it, to counter that force. But you see, in sports, you don't always have that luxury. And you could have the strongest muscles that you've trained in physical therapy, but if they are not activated at the time of contact, then your shoulder simply goes out of place. And so that's the problem, is that you can have the strongest muscles, but if they are not firing in the appropriate direction to counter the force, the shoulder loses that battle. The other controversy nowadays is, historically, when patients dislocated their shoulder, the discussion was, well, why don't you undergo rehab? If you dislocate a second time, then we'll do surgery. And if that's done, sometimes you can have a much bigger tear or a bigger injury the second time with more cartilage damage, perhaps. And also the torn tissue interface may also be scarred from the previous time that it dislocated, and you may not be able to key things in as well as if you had a fresh injury the first time and you're keying it back in. You can even see the broken edges, so to speak, to use fracture terminology. The other discussion is, when we meet patients who have an ACL tear, we don't tell them, hey, listen, why don't you go rehab it? And if your knee gives way a second time, then we'll do your ACL reconstruction. We know what the biomechanics are of the knee, and that if they have another pivoting event, that their knee likely will buckle. And then in the shoulder, however, historically, we've allowed people to hurt their shoulder again before we offer surgery. And so nowadays, there's a heightened interest in taking care of people who dislocated the first time, especially if they're interested in going back to an upper extremity dominated use sport, that we offer surgery rather than subjecting themselves to sustain a second injury. So here's one of many different treatment algorithms. We know that risk factors for dislocation include young age, bone loss. If you're playing competitive or contact or overhead sports, you have some baseline hyperlaxity. If you have other lesions, such as an Alpside lesion or a Hagel lesion that we talked about. So if you don't have any of the above risk factors, you can have a high success rate with BR, means Bankart repair. BR plus R means Bankart repair plus remplissage. Remplissage is a technique to perform a tenodesis of the infraspinatus rotator cuff to fill in the Hill-Sachs defect. So remplissage in French simply means to fill, and that's what that means. Latarjet, we'll have a discussion on that coming up. The rest of the treatment algorithm is talking about whether or not there's bone loss or not, because as I mentioned, bone loss is a very, very powerful and influencing factor for instability. Again, golf ball and a golf tee, you have a tiny little sliver of the tee missing. That is an incredibly important influence on the stability of the ball part on the socket. So that's why you have no bone loss plus risk factors and bone loss plus risk factors, and how we would treat that. But what if you have no risk factors, but you have a very upper extremity high load activity like a baseball player? So here are some statistics that we need to review. One is that with a traditional old school Bankart repair that was done open, not arthroscopic, for adolescent, say high school collision athletes, ice hockey, football, when they had an open Bankart repair, 88% of patients were able to return to play at around 6 months. Well, nowadays we do more arthroscopic. The open Bankart repairs had been done more in the 80s. So with the arthroscopic Bankart repair group, 89%, very similar to the open Bankart repair group that had been previously reported on. And compared to not having surgery, it makes sense that the people who had the labral repairs had a higher rate of being able to return to sports at the same level. So let's look at and talk about some of the goals of what we want to accomplish when we're doing an anterior labral repair, the Bankart repair. So this is an en face view of the socket, and you see the labrum, and you see some of these blue lines here with a white dot. And so the white dots refer to the anchor, and the blue lines are the sutures that capture the labrum, and we secure it with an anchor. So the red arrow, what that's showing is that when you dislocate, again, most commonly in the anterior and inferior direction, you tear the labrum, but there's also a plastic deformation in which you stretch out the inferior pouch of the glenohumeral joint. And again, if you recall the picture that showed how close the axillary nerve was, that's why the axillary nerve can get injured because of the stretch that's imparted by the humeral head that goes in the anterior and inferior direction. So if you have a loose pouch that's been stretched out, and if you just put the labrum back, but the pouch below is stretched out, you can still have instability. Therefore, you need to retension that inferior pouch. And one of the ways to do that is if you capture the labrum and capture a little bit of the pouch and you tension it and pull it upward, That's called a capsular shift. That tensions and tightens the inferior pouch. And so that's why it's important to not only perform a repair of the labrum, but also tension the capsule. And hence it's called a capsulorrhaphy or a capsulolabral repair. Some of the surgical techniques, if there are any surgeons out there, my personal preference is to use the beast chair position for rotator cuff repairs and procedures like the Latarjet. But for a labral repair, my preference is to perform it in the lateral decubitus position due to the extra space that is offered in the glenohumeral joint to be able to see the inferior aspect of the glenoid and the labrum. So when we talk of the beast chair position, this is not the beast chair position we mean, but rather this type of a position, and in the operating room, the patient's positioned very similarly like so, with the head stabilized. The lateral decubitus position, the patient is laying on his or her side, and the operative extremity is placed on a balance suspension, so that it can be, they can have some gentle separation of the humeral head from the glenoid and giving us that open space. So the positioning wise, there are different ways to do it. You can put some weights on the end, or you can have these traction setups made by different types of companies. And so in the operating room, you can have an arm that kind of looks like this. So we use small portals. Typically, we use 3 portals for an arthroscopic labral repair. Sometimes we use more. And so in this case, this is a case of a 270-degree labral repair where you can see the sutures going through the labrum to secure it down to the socket. And so this is just a video that shows the tear of the labrum that's separated from the glenoid. This is in the lateral decubitus position. The round thing on the top is the humeral head, and on the bottom is a socket. And you can appreciate how flat it looks. It is not bowl-shaped. It is not a socket per se. It's really a dish that happens to have a labrum surrounding it. And we just need to methodically go around and then fix it. And once we put the labral tissue back and then repair, this is how it looks. So despite repairing the labrum, what's sobering is that depending on which series of research papers you read, there have been reported somewhere between 10 to 26% failure rate after an arthroscopic labral repair. So I would say that sounds pretty high. And granted, if the athlete is going back to a collision sport like football, hockey, MMA, rugby, naturally there would be a higher re-injury rate in those sports. But nevertheless, these are important things to consider. So that makes thoughtful people think about how can we decrease that failure rate. And so we'll think about potentially diagnostic errors, technical errors, rehab errors, and maybe there's some patient factors and other characteristics that we need to think about. So diagnostic errors, well, diagnostic errors means that it was our fault. We didn't quite capture and understand all of the things that needed to be addressed. And so historically, a big culprit was that we underestimated the amount of glenoid bone loss, as we talked about before. Again, the T missing a sliver, tiny sliver of the wood on the golf tee, and you can have significant instability. This is a study that shows that as you lose a subtle amount of bone on the socket, the amount of force required to create instability goes down lower and lower. So you have some bone loss, then you don't need a whole lot of force to dislocate the shoulder. This is reference to the size and location of the Hill-Sachs lesion. That you can have an on-track lesion or an off-track lesion. And one of the best ways to conceptualize this is to think about having a pothole on the street. And if you're driving on top of the pothole and your tires are on either side of the pothole, you won't clunk in. So despite it being there, you're not going to notice it. It doesn't affect you, and certainly doesn't make it symptomatic if it happens in your shoulder. But if you have a big enough Hill-Sachs lesion such that this Jeep falls into the pothole, then obviously that's symptomatic. You can have a smaller pothole, but if it's in the right location, or maybe the wrong location, if you will, and your car tire clunks into it, then again, that creates an off-track lesion that renders the shoulder unstable. And so in the same way that we would think about a pothole, the size of the pothole matters and the location of the pothole matters too. So if the location of the pothole is in the center of your lane, you may not clunk into it, but if it's off to the side where your tire is going to go in, then that becomes much more of a problem. Missed Hagel lesions. So historically, the Hagel lesion had been underappreciated. Surgeons would typically say this is the type of lesion that it has seen me, but I may not have seen it. And by adding intra-articular contrast into the MRI, we're able to see this much better than we had previously when we're relying more heavily on non-contrast MRI. So yet another plug for using the MRI with intra-articular contrast. And you can see how on the right side, the dye traverses way below the usual J-shaped pouch in the axillary pouch that lets you know that there was a disruption of the inferior glenohumeral ligament. And so technical errors, I mentioned to you about the capsular shift where the inferior pouch has been stretched out, and we need to tension that as well. Initially, when the early pioneers of arthroscopy transition from performing an open Bankart repair to an arthroscopic Bankart repair, the arthroscopic group did not do as well because they were fixing the labrum, but they didn't quite appreciate how to retension the capsule. So the diagram on the lower left is showing you how an open Bankart repair used to be performed. So they would incise and make an L-shaped cut on the capsule, and when you put your finger into the pouch, it would sink in, and you can feel the degree of looseness and patchless nature where your whole finger can fall in there. Then while keeping the finger, you pull up and put tension on the capsule until your finger falls out so that you don't have that big pouch sitting there anymore. And that's how they tension the shoulder. And so nowadays, again, with advanced arthroscopic techniques, we're able to achieve a very similar result as well. And this is the picture again showing you the capsular shift that we performed arthroscopically nowadays. And you can put the anchor into a position of the bone, but you have to put the sutures through the tissue lower than that in order to pull it up. And you can also do it in reverse order. Some people like to put the sutures in first and then pull it up and then dunk the sutures in a location much higher on the clock face. One of the other things that we see is using too many anchors. So there's always a sweet spot for everything in life, and I suppose. And earlier on in the history of arthroscopy, there were suggestions that higher failure rates were seen when you didn't use enough anchors. And there's some studies in France that indicated that if you use more than 3, meaning 4 or more anchors, there was a much lower recurrence rate. So after that report, there were people that were putting in many more, and in order to put many more anchors, you needed to put them closer and closer to each other. So after that, if those athletes went back to a contact or collision sport and had a similar re-injury mechanism, sometimes they would chip that bone off by sustaining a fracture that connects a dot between the holes created for the anchors that were too close. And that's called a postage stamp fracture. And that's because of the similarity to how the edge of a stamp looks. There could be rehab errors and perhaps starting them on aggressive training perhaps too soon, not just with relation to healing of the labrum, but also their overall neuromuscular conditioning. Some people may not be quite ready to do all of the things that they want to do, but yet try them and can cause problems with healing. And of course, we talked about patient factors. If someone has physiologic laxity and the type of activities that they're performing, that can also create a higher recurrence rate, re-tear rate, et cetera. Let's shift gears a little bit about bony injuries to the glenoid. We talked about the bony Bancarts and how they had been underestimated in its importance. So the picture on the right side clear is a large fracture of the glenoid. So those are not what we're talking about, but more of the type on the left where it seems like you have a sliver of bone. And, you know, it's so easy to ignore that because to treat that is difficult. And so if you can make that problem go away by sticking your head in the sand, then that had been the way that it was addressed probably in previous decades. Well, Michel Latarjet in 1954 described the procedure to use the patient's own coracoid bone and to cut it and slide it down by a couple of centimeters and to screw that in to the front of the socket, because the front of the socket is typically where you have that bone loss. And so he's adding and increasing the surface area of the socket. And so this has been shown to have a powerful effect in restoring glenoid stability. And on that coracoid bone, you can see how on the inferior aspect of it, there's actually some tendon and muscle attached there. And so that's a conjoint tendon. And the other effect of the Latarjet procedure is that there's also a sling effect in addition to increasing the surface area of the glenoid. And the sling effect means that when you, after this procedure, when you abduct the shoulder and put it into external rotation, which is the classic instability position that creates the apprehension sign, the conjoint tendon will then cross over in the front of the humeral head and will cradle it like a lacrosse stick does in a lacrosse ball. And so that's the other powerful effect in stabilization. And Joe Walsh in France, who's probably done the most number of Latarjet procedures in the world in its history, has had a 2% redislocation rate after a Latarjet procedure, which is a profound number, considering that with an arthroscopic technique in the United States, we reported a failure rate of 10 to 26%. This is a little bit more technical than what you may want to know or need to know, but a lot of times this is described as a bone block procedure, and I just want to make mention that it actually should not be blocking anything. It should be increasing the surface area, but if it does block it and cause a speed bump type situation, then the humeral head in the front will get eroded and you'll develop isolated arthritis in the front of the shoulder before other parts of the shoulder. So here's a situation where truly a bone block was created. And if you follow these shoulders, then you can see here how quickly they develop arthritis. And so that's not the desirable way to technically perform the surgery. This is an intraoperative series of photographs where we're looking at the ball and socket joint. By looking at the where the socket ends and where the ball is, you see how the ball is hanging over the edge of the socket. And that black dot in the middle of the socket there is where the previous anchor was placed during a previous surgery that was done elsewhere. So there was an underappreciation of bone loss here. So there's that previous anchor. This is a coracoid bone, and we're going to put 2 screws through. That's going to slide over these 2 smooth pins here. And you can see how much more surface area it adds. And that makes the shoulder a lot more stable. And you can see the humeral head in relation to the socket. It seems like it's much more enveloped in there. So in the X-rays compared to the previous one, you can see how there's no bone block per se. It's just an extension. It's just adding more shelf, if you will. And the screws are parallel to the joint surface. So while we have an opportunity to look inside the shoulder during a Latarjet procedure, just to review again and emphasize how close all the nerves are to the shoulder. Remember, that's how the axillary nerve can get injured. Here's a scope looking at a shoulder that had a previous Bankart repair, and the patient failed that and had a recurrence of instability. And this is showing you on the right side, that pink area is the Hill-Sachs lesion. The left side is the glenoid. And as we actually rotate, it can engage and clunk out. So this is after the Latarjet procedure has been performed. And you'll see this structure on the right side that goes up and down. And that's a nerve. And that's the axillary nerve, my friends. Look how close it is to the shoulder. And again, remarkable that it's not severely injured every time we see a patient with a shoulder dislocation. There's actually another nerve that we have to contend with during a Latarjet procedure, and where that Freer elevator is pointing to, that's a musculocutaneous nerve, because remember we talked about the conjoint tendon that's attached to the bottom of the coracoid bone, and the musculocutaneous nerve attaches and innervates and enters the conjoint tendon about 6 centimeters distal from the coracoid bone, and so that's where that's located. So again, a lot of nerves around the shoulder. That's where it is, right there, showing you the musculocutaneous nerve and showing you the axillary nerve again there. So let's end with a case presentation, just so that we can think about how we would approach each of these cases. What are the questions that we want to ask? So you're being asked to consult on a 17-year-old high school lacrosse athlete who had a traumatic first-time dislocation of the dominant arm that required reduction in the emergency room. This individual plays soccer and basketball as well. Plans to row lightweight crew in college, to a certain line of collision sport or a contact sport. So what questions do you have? What's your treatment plan? This is where the controversy comes in. You have a young person, just based on age and activity level, there's a high redislocation rate in this age group. So do you offer surgery after the first time dislocation? If this person was going to go and play collision or contact sports, I think that increases the likelihood of offering surgery. But for someone who's going to row crew, then what do you do? So again, a lot of questions need to be explored in order to individualize and customize the treatment for each individual athlete, and to understand their goals and motivations and fears, etc. Okay, well, what about this next patient here? 31-year-old surgical resident. This is a dominant arm, says that he stopped counting dislocations at 20, required 3 reductions in the emergency room in high school, had 6 dislocations reduced on the field in high school. Reports that subsequent dislocations are easier and easier to have happen, and it's also easier and easier to pop it back in. Even reports having had 1 subluxation while stretching in bed. What questions do you have now? What's your treatment plan? And so, when you hear the story, I mean, there seems to have been a lot of dislocations. You would say, well, clearly, this person sounds like they need surgery. And in fact, I'm concerned about a missed Hagel tear, or maybe some glenoid bone erosion, because of the magnitude and the number of dislocations. But here's the thing. This is a 31-year-old surgical resident. So does this person have time in their training to take time off to do rehab appropriately, or to have surgery at all? And knowing the lifestyle of a doctor, is this person finished from being active again for the rest of their lives, because they're just going to be working all day and all night long in the hospital? So again, joking aside, we need to understand the goals and other life factors. So how about this dude? 45-year-old orthopedic surgeon with 3 kids, has a busy practice, sadly not active anymore, never had surgery, and the last shoulder dislocation was 12 years ago. Clearly, you wouldn't suggest that this person has surgery at this time. How about this old guy? 52-year-old orthopedic surgeon who'll be 53 next month, with 3 kids, busy practice, not active anymore, sadly, never had surgery. Last shoulder dislocation was 17 years ago. And so now, clearly, I'm not interested in surgery. And this was a story of my life. And so I think now all of my friends who are orthopedic surgeons who know my story, all they ask me is, hey, which one of us are you going to have do your shoulder replacement when it starts creaking on you? The whole point of this is that even for the same individual, at different decades of their lives, they may make dramatically different decisions and have different preference for how they want the shoulder treated, or any joint treated for that matter. And so that's why it's important to assess each individual's goals, what their hangups are, what their motivations are, what kind of activities they want to get back to. When I was 17, I would say I want to get back to everything and anything I can think of. When I was a resident, I thought, well, I want to be able to do this and that, but I don't really care to do X, Y, and Z. And so I think having that understanding with the patient is so critical. So I would encourage you to spend the time to get to know your patient as a result. And so that comes to my last slide. Thank you very much. Wanted to open up for any questions and dialogue, and would love to stay in chat.
Dr. O, we have 2 questions here.
Is it in the chat? I can try to open it.
Yes, under the Q&A.
Hang on a minute. Let me stop sharing my slide, maybe. Okay, and let me find it. Okay, now the Q&A button shows up. Okay, does the ABER view require use of an open MRI due to arm position? No, in fact, as you saw, it gets positioned right above the head. So it's through a regular MRI. An open MRI typically has much lower resolution. So I don't find the open MRI to be helpful at all. If you're in a situation to get an open MRI, I would say whether it's for anxiety or size of the patient, if it's anxiety, I typically offer them some short-acting anxiolytic for them to take in order to go through a regular MRI. The quality of the pictures are dependent on the strength of the magnet. And if you have an open MRI, the magnet is farther away. So instead of seeing a crisp picture, it's like looking at an old black and white TV screen with the poltergeist screen on it. So I really don't trust open MRIs for that reason. So I would discourage you from using an open MRI in the first place for any reason. Now, all right. Nadine has a second question. With the Latarjet, do they get short head of the biceps tendonitis or pain with throwing? None that I've seen and none that have been reported to my knowledge. But I'm sure if we keep looking, we might find some people. But yes, we have not seen that as a problem. Having said that, I guess there is some controversy about doing a Latarjet procedure on overhead throwing athletes. Historically, there could be anywhere from 0 loss of external rotation to some degree of external rotation, as well as floor elevation after a Latarjet procedure. So the fear is not so much getting tendonitis or other problems, but are they going to lose some of the critical range of motion? So for an overhead throwing athlete like a pitcher, each degree of external rotation is equivalent to about 1 mile per hour on their pitch. So if they lose 3 degrees of external rotation after a Latarjet procedure or a rep massage or whatever other shoulder procedure, at the highest levels, if you used to pitch at 92 miles an hour and now you're pitching 89 miles an hour, that could be the difference between a Division I scholarship or not. That could be the difference between pitching in AAA versus AA. So that does have some implications for that. Okay, we have Jessica here who said, I recently had a shoulder dislocation with 18-year-old male football athlete, first-time dislocation. We were able to reduce the shoulder, immobilized and rested, and was advised to see sports medicine ortho for further eval. Player later goes against the AMA and went back to play and dislocated the shoulder again. Aha, sounds like me. I did that. This time, EMS was summoned as at the point all the ATCs decided not to treat shoulder due to liability. What do you think could have happened in terms of injury? So I guess I'm trying to understand the crux of the question. I think there are a couple of different things to think about here. If the school's ATC and the coach are aligned, the athlete should not even give allowed an opportunity to go against AMA and went back to play in the same game at a high school. So I think that's from more of a systems perspective. I think that requires discussion with the coaching staff, that either the team physician on the sideline or the ATC has to give the thumbs up for the athlete to go back into play. One of the tricks that are taught sometimes for sideline covering clinicians is to hold the helmet of the athlete that you're trying to assess so that they don't tuck the helmet and just go sneak back into play. I understand that if they run out into the field and they're involved in the play, it's not like you can go out there and tackle your athlete and drag them out. So by holding their helmet, you're not going to let them go back in and play. And also, if the coaches are aligned and they don't get the approval thumbs up from you, that they don't let them in, they pull them out. So that's the first thing. So that already then precludes an additional liability issue of a second dislocation in the same game. So I guess when ESMS was summoned and all the ATCs decided not to treat shoulder due to liability, does that mean for that specific athlete, or do you mean in general for any athlete who has a shoulder issue? So clearly, for other athletes who have a shoulder dislocation on the sideline, you should be treating them. It's not a liability issue, but I think for that particular athlete, I can understand how you may approach it that way. But just to be clear, I think for any other athlete, just because one patient decided to act in a certain way, it doesn't mean that you stop treating other patients who need your help. Yes, Jessica, thanks for the clarification. Yes, it was for that athlete. So yes, this is a tricky situation. If EMS was there and there are a couple of different things to consider depending on how long it takes for EMS to get there. As you know, the longer it takes to reduce and you have spasms and things like that, it could be harder to put the shoulder back. But I can't fault you at that point with a second dislocation. Likelihood in that age is that it's another simple dislocation, but could there be a fracture component and all of these things? So yeah, I don't think you could be faulted. What I might suggest as the thing to do is, as I mentioned, about neurovascular injury. So you might want to at least just document the neurovascular status so that you don't become accused of not taking care of an athlete who had a neurovascular problem, right? So I think that's the other liability issue, is that once you document that, you can say, hey, it might be safer for you to go to the ER situation, get x-rays, and then have it formally taken care of there. Okay, and there's a further clarification here. It's for a football college scrimmage game and had standing orders with the agency that hired me. I was covering for the visiting team as a per diem ATC. Okay, so those are more systems and practice-based questions, I suppose. And yeah, so there's some nuances about each of those situations. And I guess I'm just speaking more from a medical management perspective. But yeah, I think, again, whenever we have issues like this in the course of taking care of patients, we want to set up the system so that we are not caught in situations like this. I would say, at the beginning of the game, if you're just coming for the day, you don't know the coaching staff very well, that's another reason to go to the game early, way early, before people are getting hyped up before the game, so that you have a calmer situation where you can meet the refs. They know who you are, the opposing team knows who you are, and your own coaching staff knows who you are, and that you're very clear on the fact that if there's an injury, you make the call. So, you don't call plays on the field, and they don't make medical decisions. And I think that has to be clearly communicated before the coin toss. Lorenzo, nice to see you here. Are athletes at higher risk for degenerative changes such as arthritis following stabilization surgery? How do you counsel them regarding long-term outcomes and preventative strategies? So one is that in the same way that we know in the ACL literature, as we develop arthritis slowly through our lifetimes, once you get an ACL injury, at that point, that slope has already increased, right? So you have release of metallomatrix proteinases. There are the internal milieu and the chemical changes that happen already start to degrade some cartilage, and there's impaction fractures and kissing contusions and the like. So at the time of the injury, you already now are on a slightly different path already. So similarly, once you have a shoulder dislocation and you have all that bleeding and release of different chemicals and cytokines, et cetera, in the shoulder, the degenerative changes will start. And as a result, that shoulder will look different 10, 20, 30 years later than your contralateral side that didn't have an injury. In terms of, and the number of dislocations the violence of the dislocation, the amount of cartilage damage, the amount of bone loss, all of those things have an effect on developing arthritis, as you know, and how much damage they have on the cartilage on the humeral head versus the glenoid. Do you have bipolar disease on both sides versus one? So all of that contributes to arthritis progression. In terms of surgery, in the old days, there have been some other techniques that are no longer done now, like the Magnuson stack or putty plat, where you're just tensioning so that the shoulder doesn't dislocate anymore, without really regard for future development of arthritis. It's just, hey, how do we treat this dislocation now? So let me give you this historical perspective. Some people may not know, but Hippocrates described one of the earliest invasive treatments for shoulder dislocation. And what he would do is, there's some pictures in old scrolls, I suppose, of the patient laying down on their back on the ground. And it shows that the treating individual is holding the patient's hand. So the shoulder is in the slightly forward elevated and abducted position. And they take a hot burning steak and shove it into the armpit. And I presume the patient would scream and just pass out maybe. And when they woke up, guess what? They never dislocated again. You know why? Because they just burnt that area. And if you didn't give them a brachial plexus palsy, you develop such scarring that they limit their range of motion so that they can't abduct and they can't externally rotate as much as they used to. So guess what? If your arm doesn't go into the abducted externally rotated position, they don't dislocate. Well, they may not be able to lift their arms either, but that's what I mean, is that some of these older procedures would really tighten the shoulder to a point where they lose range of motion, and they develop arthritis due to increased cartilage contact pressures of the humeral head on the glenoid. But guess what? They don't dislocate. And so that's why I think we have to be thoughtful about technique and how we do this, and how we tension. And that's why, when I was in Boston as a doctor for the Red Sox, there are many, many shoulder surgeons, but they did not want to touch baseball pitchers because it was so hard to dial them in to keep their shoulder stable, but keep them loose enough to be able to perform at a high level to maintain their external rotation. And I think that comes from judgment. And they say good judgment comes from experience, and often it means having made bad judgments that give you that experience, right? So it's a trial and error, it's a learning curve, and we need mentors for that, as well as volume, and as well as doing them a lot, and having gone through, I suppose, some bumps along the road in the early years to get to that level. So yes, so just like everything else in life, there is a sweet spot for everything. You just cannot make the shoulder as tight as possible. That is not the goal. It's to make it stable, but still give them full range of motion and function while reducing the recurrence rate. No difference than when we do ACLs, right? You just can't make it as tight as possible where they don't have full range of motion. They have increased cartilage contact pressures, and people get arthritis due to overtensioning of the ACL as well in the knee. Any other questions, comments, thoughts?
I think that's it, Dr. O. Well,
right.
thank you all for taking time out of your schedule to join us this afternoon. And thank you to Dr. O, as always, for sharing such valuable information. I hope you all found this to be very extremely helpful. And if you still have any questions, please email me, which you will find in the chat box. And then I will get back to you as soon as possible. Again, if you would like to make an appointment, please call 1-844-407-4070 or go to rothmanortho.com. Thank you.
Thank you, Alana. And for everyone else, feel free to reach out to me. Some of you know me personally, so contact me by email. For those who don't know me, you can contact me through social media channels as well, Instagram and LinkedIn and the like. And you can find me on the website at rothmanflorida.com. Thanks, everybody.
Thank you.